welcome to this discussion on the impact of race and gender on global healthcare. My name is Ilda Kuleba, and I'm the country director of Mothers to Mothers in Mozambique. And I'm joined by Dr. Joya Queer-Perry in Washington, D.C., who is a thought leader around racism as a root cause of health inequalities, an obstetrician and gynecologist, founder and president of the National Birth Equity Collaborative. Thank you, South by Southwest, for giving Dr. Joy and I a platform to discuss these important issues. So it's great to be here with you, Dr. Joya, and looking forward to having a great conversation tonight.
I'm excited.
Yeah. So just to kick off our conversation, I'd like to ask what led you into a career fighting inequality in maternal health through your own experience as a Black woman and a mother?
Yeah, I mean, I would say that my first experience was I was pregnant in college and, looking for a gynecologist, looking for a Black woman to be my OBGYN, and they were all booked up. It was hard to find. As you may know, Black women only make up 2% of the physician workforce. And so we are like unicorns. And so that was the beginning of my going into obstetrics and gynecology. And then after having my child, I had a son who was born premature when I was in medical school, and he weighed about a pound. I was only 22 weeks pregnant when he was born. And my only risk factor, according to the CDC and all these journals, was being Black. I was married. I was intending to be pregnant. I was healthy. I was skinnier than I am now. So all the things that they check off where we blame and shame birthing people for their birth outcomes, I met all those parameters. So the only thing that I didn't had was my Black skin. And for the longest time, because we teach the belief that Blackness is the risk factor, I believe that the reason I had my son early was not because of racism, but that there was something innately about being Black. But there's no Black gene, there's no Black kidneys, no Black cervix, no Black vagina. So, but there is racism, and racism causes biological harm and causes stress. And so that is why I fight really hard to reframe the conversation from blaming and shaming birthing people around the world for outcomes, but looking at the structures and the policies of racism, classism, and gender oppression, and how that is what causes health inequities.
Yeah, I mean, it's a very powerful message, and I think it speaks to how society looks at certain groups of people. My personal inspiration to pursue a career focused on improving access to health services for women and families in vulnerable and HIV affected communities started in my youth. I was about 16 years old. I volunteered at the Mother Teresa orphanage in Ethiopia at the time. And up until that moment, I really didn't know about HIV. And at that point, I learned about the devastation of AIDS and the inequalities in health outcomes, specifically when we were looking at women, when we were looking at children. I saw children who were abandoned by their families because they were living with HIV, and oftentimes because their families didn't have access to HIV treatment, or women who were ostracized because they were living with the disease, and their families didn't want to be associated with them. So now, as the country director of Mothers to Mothers, a program that is committed really to working with women and children, families across 10 sub-Saharan African countries to support and overcome stigma and barriers, access to healthcare. And I think we've done that well and seamlessly with working with frontline health workers. They're local women, we call them mentor mothers, and they support other women and families within their community to get the treatment and to address a lot of these barriers and inequalities. And in the last 20 years, Mothers to Mothers was able to create jobs for more than 11,000 women living with HIV who are among the society's most marginalized. So I do think that there is a need to look at these inequalities and see how do we address them in the best manner. So as we talk about inequality, I'd like us to probably talk a little bit about your experience and racism and gender inequalities and how the systemic racism and gender inequalities create these health disparities in the US.
Yeah, I mean, I would say not even just in the US, it's around the globe. The US exports our racism and our gender oppression to other places. So for example, when we work in countries in the continent of Africa or sub-Saharan Africa, we spend a lot of time focusing on not undoing the harm of the history of colonization. We don't even bring up the fact that we extract and export in marginalized communities. We work with leaders who are not invested with the local women the way that Mothers to Mothers is, where you're not working with women on the ground, you're actually working with leaders. And so I just want us to be clear that racism is not a US constructed or even operationalized structure or framework or policy. It is a global phenomenon. A belief in a hierarchy of human value based upon skin color plays out in how we do policies in everywhere from Asia to the continent of Africa to the United States to the Caribbean, and the confluence of how this devaluation of individuals based upon skin color, along with our gender, shows up in the outcomes that you see in the United States. So the United States has the worst maternal health outcomes of any industrialized nation. In fact, we're the only high income nation where more women are dying in childbirth each year than less. So my daughter is more likely to die in childbirth than I was when I had her 28 years ago today, actually. And so it's important for us to think about why that would be, why a country that has as much wealth as the United States has not provided for the ability to people to thrive inside of childbirth. And when you look at some of the risk factors, when you look at the reasons that women are dying in the childbirth in the United States, especially for Black women, there is a lot of similarities to the situations that are happening across the continent and around the world when it comes to, as you said, stigma for the HIV positive women, right? Who values birthing for Black women? If you're coming into the hospital and you have, and you're seen as less valuable, you're not going to be treated the same way. Your hemorrhage will not be treated in the same way. Your hypertension, your blood pressure issues. We have data that shows that despite income, despite education, even if we show up to prenatal care in the first trimester, we are still more likely to die in childbirth than our white counterparts. And so the CDC replicated the data that shows that even we are 5 times more likely to die in childbirth than our white counterparts when we have a graduate degree. So a white woman with a graduate degree is 5 times more likely to survive in childbirth than a Black woman with that same graduate degree. So when we understand that just not valuing people, seeing them as less than human, seeing them as not capable to fully thrive and make decisions on their own, deciding that our job is to plan for them and to save them without actually investing in their ability and their capacity to thrive, that is harmful and that causes all of us to have the not the outcomes that we wish and desire for everyone.
And thank you for that. And before I go into the similarities that I found in Mozambique and across sub-Saharan Africa, how do you think this can be addressed in a holistic manner?
We have this language we talk about now, especially as the world after the murder of George Floyd and the movement for Black lives highlighting the impact of global anti-Blackness, that we have an opportunity to have some truth telling, some truth, racial healing and transformation. And that truth telling needs to be a global conversation, the truth telling of what the US and the other countries have done in places like Mozambique, right? How our continuation of devaluation of countries, of continents, of leaders, of human beings, of people continues to be harmful for folks. And so I do believe a common way to move forward, an important thing to do to move forward is start with truth telling. We have not had truth telling around the history of how we got here, why we had a belief in a biological basis of race, and the importance of how it is to move forward to undo this harmful hierarchical belief system of white supremacy culture. That was never a fact and never a truth.
Right. And, you know, race and gender, as in the US, have a tremendous impact, be it in Mozambique, across sub-Saharan Africa. And even though most people identify as Black, there are colonial legacies that have led to structural racism that discriminate against or favor certain groups based on ethnicity or how close their heritage may be to a formal colonial power. But I think oftentimes when we're looking at these health disparities, we need to look at more tangible issues. I think there's health disparities brought on by different factors such as geography, such as cultural norms, structural discrimination, things that we can tackle in a more tangible and direct way. So to start off, when you look at geography and urban versus rural, you find that a significant proportion of the population in sub-Saharan Africa lives in rural areas, and many people have to travel long distances to reach the nearest health facility. And so you have women who don't make it to the facility to give birth. Instead, they're giving birth at home, accompanied by a traditional birth attendant or a relative, not someone with a medical training, resulting in high rates of maternal and child mortality. And so how do we address that? What do we need to do in areas where surely the structure around health services are diminished because of the inequalities, because at the time during colonial past, those weren't locations that were seen as priorities because they had mostly the local population. There's also, when we look at gender inequality, most countries across the continent is characterized by women's subordinate status. You know, women still need to ask for permission to seek healthcare and to take medication. And that inability to control their own lives or to make a decision about their own bodies, that is very detrimental to what sort of quality healthcare they can seek. We have high rates of young marriage, there's early pregnancy, and sub-Saharan Africa also has the lowest level of adult female literacy. So when you talk about even graduate level women, Black women in America are still dying, imagine when 57% of the adult population is literate, how does that translate into being able to seek health services? And when speaking specifically about HIV, which is where we often hone on with Mothers to Mothers, we're seeking to build more gender equal, inclusive communities in all the countries in which we work. And we do that by equipping the women we employ and mentor mothers, take the information to their communities and really become role models for other women in their families. And we thrive to make that and put that into a multiplying effect in their community. So we're really looking to, as you speak, I think we're looking to flip the narrative on its head, helping the vulnerable and marginalized from a space of disadvantage and to empower them so that they can make those decisions, so that they can partake and not be victims to what happens to them.
And I love all of that. And I would just say that is what the narrative that we're trying to flip is also that is not distinctly, that is a global problem that includes the US, right? So like there are women in the US who don't get to control their bodies, and they're usually marginalized Black, brown, and indigenous women. There are women in the US who are, the highest rate of HIV is in Black women, that is the HIV numbers. And so that's still the devaluation of certain groups of people who don't have access, who have been historically, the legacy of devaluation continues today, right? So the more that we can say we're all in the same boat, that this is not some far off thing that's happening in Mozambique, that is happening actually in Memphis, and that the same people that are devaluing, the same funders, the same philanthropy, the same organizations that will invest in working in Mozambique need to understand that if they're hierarchical, if they are thinking they're going there just to save those folks and they don't have problems at home, that's an issue, and that we have to build power in Mozambique. And also in low and marginalized communities in the United States as well, because that's really where we will grow as a world, when we see that all of us are in the same boat. Like, I love that I get to work with you all, that Mothers to Mothers is working around a global space, and because we see that there is really no difference in some of the, it's a gradation in the severity, but it's still a continuation of a legacy of devaluing groups of people.
I agree.
Yeah.
So 2020 was marred by the COVID pandemic. I think there's nobody that hasn't lived it. And COVID disproportionately impacted Black and Brown people, communities in the US. And now these communities are being vaccinated at a much lower rate than white Americans. Can you talk about these challenges and why you think COVID is laying bare inequalities in healthcare?
For sure. Well, we were really concerned when COVID was being racialized by our past president to be called the Chinese virus. And it was thought of as this some foreign thing that people are getting on airplanes. In fact, in the beginning, in the beginning in New York City, because it was thought of and bias was creating the policies, you had to have a had recently traveled to Italy or China to even get a test for COVID-19. So we knew that that was going to have a huge impact on the Black and Brown community, because although we don't have passports and folks might not have ever left the Bronx, when the people who went to China and Italy and were exposed to COVID came back to the United States, they were staying in hotels where people who were Black and Brown were flipping the beds and cooking the food. And they were getting their packages delivered from people who lived in those communities who might have never left their borough, but they couldn't even get a test because the way that the bias works said you only can get the test if you've recently traveled. So that continuation of not understanding biology and overlapping our racist biases into how we create policies showed up in the fact that Black and Brown people are still the most likely to die from COVID. When you say things like you have to have, you're more likely to die if you have a pre-existing illness, you think about places like Louisiana, where I'm from, where for generations you couldn't have access to health insurance unless you'd been a childbearing adult. So that meant generations of men had no access to health insurance. They were working men. They're people who work in the same hotels and restaurants that people love to come and party for Mardi Gras, but those people are not protected. They're powerful, but not protected. They're not given access to health coverage. So how would you know if you have a pre-existing illness if you've never even had health insurance to be able to go to a provider to see if you have high blood pressure or diabetes? So then you're more likely to die because you're not even aware that you have this pre-existing illness. The idea of going to your private doctor in order to get tested, we're less likely to have access to providers, to health insurance. We're more likely to still be working. Only about 1 out of every 5 Black persons and Black, Brown, and Indigenous persons can work from home. So the people are out working still. They're the people who are delivering your mail. They're the people who are bagging your groceries. And so they're essential, but they're not being protected as if they're essential. They're not getting access to the protection of having masks. They're not allowed to have paid leave. They're not even getting hazard pay for risking their lives so that we can all have access to our food and the things that we want. So it is not surprising that COVID has laid bare once again to the devaluation. What is new is that we are able to push back on the narrative. So normally, there was a state senator in the state of Ohio who said, oh, well, the reason that Black people are dying is because they're just not as hygienic. They're not as cleanly, right? So that is a biased and racist narrative that was for years inside of public health, the belief that the reason people of color died more is because we were less cleanly, which is odd because people hire us to work in their houses to clean up behind them. So this juxtaposition between belief that we're supposed to be so dirty, but you want us to come to your house and clean your house. So that is what racism does. It's illogical, and it makes people make choices that are illogical.
And as we speak about the U.S. and what COVID, the inequalities that it's laid bare, I think about through this pandemic, the fact that while millions of people have been vaccinated in North America and Europe, very few vaccines have reached the African continent. And there's still no clear indication when large-scale vaccination efforts will get underway. According to December estimates from the People's Vaccine Lobby Group, 9 out of 10 in the poorest countries are not expected to receive a COVID vaccine this year. And for countries in Africa, where you see that there's been great, I feel like there's been great development made around vaccination campaigns in the last 30 years. Mass vaccinations in communities for polio have been done. But now you have COVID coming in, potentially undoing that. And not just because there's no access to these vaccines, but there's also a lot of misinformation on the safety of these vaccines, the effectiveness of these vaccines. So I think that countries cannot look at themselves as siloed, but we really need to figure out that this goes beyond moral imperative, but there's global health and economic imperatives of leaving huge regions around the world unvaccinated, because we end up with a virus that might mutate, and these vaccines may not be as efficient. So I think that the global inequalities in healthcare with access to vaccines, and just looking at the fact that African countries have procured doses that will secure coverage to maybe a third of the population, that's concerning.
Oh,
And
sure.
so what do we do? Or what's the information that needs to be put out there?
And it's similar here, like we know that Black and brown people have the highest rates of catching and dying from COVID, and yet those communities are not getting the vaccines. And even when we put centers in those communities, like here in DC or in Las Vegas or in across the United States, white folks are traveling to those communities and taking the vaccines that are meant for the people who are in those Black and brown communities. So we have not created really still this ability to actually make sure that the people who are the most impacted receive the vaccine. But we know how to do it. Let me tell you why I know we how to do it. In the same place, Las Vegas, the health department sent vaccines to the Black community. They also sent vaccines to a white community that had homeowners who were elderly. And they said for these folks, they gave them more. And they said, you can't get the vaccine unless you actually are part of this homeowners association. So they valued the homeowners so much that they said, no one can come from another community to get these vaccines. These are for you. And they coordinated with that homeowners association to make sure that happened, because they knew that was really important. When they sent it to Black community, they just sent it to a grocery store, said people sign up online, refresh your browser, as if people who are over 70, no matter your skin color, are sitting around on a computer, refreshing their browsers, trying to get to an appointment. And so you see in line, many white folks driving from other parts of Las Vegas to get the vaccines, because the people who are in that community did not have access to internet and could not refresh their browsers to get those appointments. So you're structurally creating the same thing that's happening in Africa, where you're not getting the vaccines to the people who actually need it. And capitalism is not a public health strategy. If we're going to ensure that we get the most marginalized people vaccinated, then that we need to make sure that people in Africa and sub-Saharan Africa have access to the vaccine, because the virus does not care that we are not interested in going there. The virus is going to find us.
Absolutely. Do you feel, I mean, I spoke a little bit about distrust, and do you feel that there's a lot of distrust among Black Americans?
It's funny because every media outlet talks about this distrust. And I know a bunch of Black folks who are online trying to get vaccines. So if we could have a deeper conversation that yes, there is distrust, and also there's a reason to have distrust, and you are still structurally not giving the vaccine to the people who need it. We have not created policies to ensure that happens. And so why should people be trusting when you don't value them, right? And so that is that's the full conversation. So focusing on distrust is once again blaming and shaming communities of color for not getting the vaccine without being honest that we have not even created the strategies, the policies to ensure that they would get it. My father is a 70-year-old Black man who's a physician who still has not gotten vaccinated. We keep refreshing the browser, putting his name in on the little computer list. It has not happened, right? So there are plenty of people, and he's one of many. There are plenty of Black people who are not hesitant, who want it very badly, who are not being able to get it. And so let's have that honest conversation.
And that's a great perspective, because I think the narrative that's going out there is that Black people are not getting vaccines because they're distrusting of the vaccine. Exactly. And so that then perpetuates the idea of not distributing them as we need to.
Mhm.
And I think that on the other side of the pond, Geopol, the survey looked at various countries on the continent to gauge whether people felt like the vaccine was safe or effective. And the two countries in which Mothers to Mothers operates, Mozambique and South Africa, it showed that between 54 and 56%, Mozambique and South Africa felt that the vaccine was safe. I mean, of course, when looking at these numbers, we would have to tease out gender, class, urban versus rural. Effectiveness, there was a 55% of those surveys thought that it was effective, 60% in South Africa. And when also asked those who would definitely or most likely take the vaccine, Mozambique, we got about 68%, South Africa 69%. I know that in more developed countries, these numbers may come off as very low.
No. I was afraid what you were going to say. So I'm excited. Those sound great.
So I think
that's the thing, because that's probably those are similar numbers to Black and brown communities in the US, truthfully, right? Like people kind of believe it's effective. They're going to go get it. And so the narrative that they're not going to and they don't believe is only in the media's head. It's only what people want to perpetuate so that they don't have to act. There are many excuses for inaction, and blaming the individual actors is a great excuse to not have to act.
Yeah. And I think there's to go along with that and to support these communities, we need to tack this on with education. And I think it's important that people have the education and support and the accurate information about the vaccine so that they feel confident in taking it and knowing that it will benefit their health. And it's not just about the individual benefit, but it's really about their community. Yeah.
Sure. And Dr. Kamara Jones, one of my mentors, she talks about this. Like, it's difficult for a community who has never been invested in. Then you need to show up and say, take this shot, trust us. Like, that's not good. So you need people who are from the community, who they recognize, who feel familiar. The same work that you all have been doing, I'm sure, in HIV. Like, you can't fly in some, dude from the UK to come to Mozambique to talk about his experience living with HIV. Like, that's not going to get you there. You need people who are from the community. The messenger and the message matters. So when it comes to vaccines, having people from the community, and then also not just talk about take this vaccine. Where is my protection? Where is my money for ensuring that I have health insurance in general? What's going to happen to my family? Do I have money for if I become ill, for my child care? So when people trust, not that you're just going to give them a shot, but that you actually want to ensure that they're healthy, that you're going to ensure that they have the ability to make choices and to live the lives that they deserve.
Yeah, absolutely. And what I can tell you about the 2 decades of experience Mothers to Mothers has had in educating people about HIV and supporting them across treatment is that it is essential that vaccine education and rollout is driven by community-led initiatives. Local front health workers will be able to build more trust by modeling the way. If they take the vaccine, then they can convince people that the vaccine is safe and effective. And that's really a space we plan to see ourselves, because we know that it's imperative that the population and the communities that we reach have that information and can access the vaccine when the time comes. Still talking a little bit still on the COVID-19, and I think we've touched on this as we talk about media and we talk about towards COVID-19 and the Black population. But how can we ensure that the global response to COVID-19 takes into account health disparities and doesn't worsen the barriers to access healthcare?
Yeah, and I think you and I have been talking a little bit about this, right? Like, what we have to do is actually listen to the people who are in the community, and then follow their lead. If we are clear that the people who've been in leadership so far, when it comes to public health and healthcare around the globe, have made decisions that have caused inequities, right? Like, clearly, We can't then rely on those same decision makers to magically now, when it comes to COVID-19, make some new strategies, right? Like whatever they're going to come up with is how we got here, right? So why it's important for us to think about, perhaps it's time for us to actually listen to people in Mozambique about what would be the best way to get treatment and access to the vaccine for people in Mozambique, right? Like it should not be someone sitting in France or in Switzerland or in New York City talking about what is the best way to get to end the global inequality. That you have to actually talk to the people in those countries, in those communities to do it. And that reframing and saying who's the expert on how we see public health, how we see healthcare, that people in community are actually the experts about the best way to get things done. That is how we're going to end inequalities.
Yeah, and do you feel that the focus on COVID-19 has taken away from other health areas that need just as much attention?
Well, I would hate to, I don't like to think of it as pie, right? So I think of the COVID-19 focus as an opportunity for us to see the through line between when you don't focus on the health of women and birthing people, you see poor birth outcomes. So we see COVID-19 exacerbating the inequalities that we already saw when it came to birth outcomes, because the mistrust and the bias that people had when they were actually in person seeing providers. Now they're on the phone. They're not even in person anymore. So the provider decides who comes in, how often they come in. Their biases show up even more. Many people are dying at home because they don't have access to health insurance. They don't have a provider. So it's not that COVID-19 is taking attention away. It's actually highlighting the health inequities when it comes to our work around reproductive health, contraception, abortion. All of those things have been impacted by this pandemic. And then the narrative and the inequities have worsened because we still have not listened to and focused on the people who are the most impacted.
No, absolutely. And I think some early estimates have talked about the direct impact of COVID-19 on child and maternal mortalities, and talking about more than 2 million additional child and maternal deaths are estimated over 12 months due to disruption to essential health and nutrition services.
Exactly.
So as many countries around the world and on the continent put on these restrictions last year, people didn't know when they can go to a health facility, where to access essential and vital health services. So it's important that we don't fail populations and that they continue to receive the health services that they need, so that if this pandemic is over, we don't find ourselves with these now having to tackle health disparities and take decades to recover from what's happened in the last 15, 18 months or
And I think the other thing that been some innovations in healthcare because of COVID. We're doing more telehealth, so more electronic health, more. So I think, what is this opportunity for us to say, okay, so we couldn't do in person, but you mentioned rural. For rural US, rural Mozambique, rural South Africa, we've never invested in infrastructure for them to receive care. We just say drive downtown, as if people magically all have cars and all have access to being able to drive to some medical center. So how do we take this moment of innovation, of understanding that during a pandemic, people can't drive downtown? Guess what? They can't if it's not a pandemic either, right? You're still investing in really building out a telemedicine, a telehealth infrastructure across the world so that we can have a global world that is more healthy. So I'm an optimist. So there has been a lot of people there's been excess death. There are many people who are not receiving care, but we're learning some important things about how you would provide care when people don't have access to transportation, that they still won't have access to print transportation afterwards. And I'll give the example of, I was the medical director of clinical services for the city of New Orleans after Hurricane Katrina. So that meant my job was also to ensure that the people who didn't have access to transportation could evacuate. So there are about 30,000 people who in the city of New Orleans who do not have access to a car. That doesn't mean that they don't own one. They don't even know anybody with one, right? They have no way to get out of harm's way if a storm is coming towards the city. That doesn't change when Hurricane Katrina left. We didn't invest in those people. So still today, there are about 30,000 people who still don't have access to a ride we had to change our technology to ensure that we know who they are, where they are, and we have an ability to make sure that they get out of harm's way if there's a storm. That's the same thing we should be doing now when it comes to COVID. They're not going to magically all be able to drive into town to get care after the pandemic. So how do we invest in ensuring that they get access to care in their rural communities, in their home, where they live?
And I'm glad you mentioned that, because we've had to, Mothers to Mothers has had to adapt a lot of its work during the pandemic, looking at how do we access, or how do we reach the 40% or 50% of the population that lives in the rural areas and don't have access to a phone, or those who do have access to a phone, can we still keep in touch with them? Many of our mentor mothers went from delivering face-to-face engagements to peer via phone. We didn't think that was possible. I think all we used the phone was to remind women, please come back to the facility. But here we were having meaningful engagement with our clients on the importance of coming back to the facility. We had clients who were reaching out to our mentor mothers a lot more during the pandemic, on the phone, sending messages, and feeling that at least they had this connection to the outside world, that even if they were restricted from going to the facility, they had a mentor mother on the other end that can answer their question. And so I absolutely agree. Like, how do we ensure that we are adaptive, that we are still providing the necessary services to our population, to our communities, despite the challenges that we're facing right now? So it's imperative that we keep that in mind. So Dr. Joya, last year, aside from COVID, another topic that was all over the news, and it became really a global movement, was the Black Lives Matter movement. And I'd like to get a sense from you. Do you see opportunities through the Black Lives Matter movement to raise more awareness to address systemic racism in healthcare?
Yeah, so for us, the Black Lives Matter movement has been critical. The language around understanding how racism impacts our health comes from the language that they utilize talking about police violence, mass incarceration. So this opportunity, as the world watched the murder of George Floyd live, many people who'd thought about police violence, who'd heard people talk about it, but say, oh, it's not that bad. Seeing a Black man murdered by a policeman, and seeing the face of that policeman with no remorse, with no regret, looking as if it was just another day for him, all filmed around the world. It really was a moment for the world to think about, well, what are we doing? How do we devalue Black people globally? How do we say that their lives don't matter globally? How does that show up, not just as someone being mean-spirited or calling someone a bad name? This is not about people's being one individual. There's a structural impact. There's a reason why around the globe, countries, institutions that have people who are Black get less resource, get less visibility. There is a history and legacy of white supremacy that's 500 years old, right? That was replicated from the US to Germany, all around the globe, to the ways that we even talk about colonization and the global, even the word global North and global South comes from a racist history and a racist ideology around who is deserved and who is developed and who is undeserved. And so there's an opportunity for us really to think and undo 500 years in a history of a world that's thousands of years old. We can stop devaluing people just based upon their skin color. It's a choice. It's a choice for us really to move away from and believe and understand that we're all the same, that there's nothing different about us based upon our skin color or our hair. That doesn't make us more prone to violence. That doesn't make us more likely to have more outbreaks of disease or illness, that all of those was misinformation. And so the movement for Black Lives really just says all people matter. Black lives do matter, because for so long they did not, in policy and in culture.
Yeah, absolutely. And Black Lives Matter may not have been branded as such before, but it's definitely a global movement, and it resonates deeply with Mothers to Mothers. Mothers to Mothers is an organization that was born in Africa in response to a time when Black lives didn't matter, when resource-rich countries had access to life-saving treatment for HIV, while people across Africa were dying of AIDS. And the world didn't care so many Black lives were being lost. So for us at Mothers to Mothers, we remain committed to making sure, like you said, all people in all communities have equal access to healthcare. And where you live in a world where the color of your skin, the sex really shouldn't determine your health. Not in Africa, not in the United States, not anywhere. So it truly is it truly is a converging point for us. It's not a US topic, but it's really a global issue that needs to be seen as such.
Yeah, and I had a great opportunity of going to Kenya last year, but pre-COVID for UNFPA, and thinking about how it resonates, this idea of understanding that Blackness has been devalued everywhere, even on the continent of Africa, even and so I think the reason that it's a global movement and people understand it because they do understand that this hierarchy exists in all these countries, and it must be undone in all the countries. Yeah.
Absolutely. Sadly, I think we're coming to the end of our conversation, but I'd like to just give you a chance to tell people who've been inspired by this session how they can take action and forge new partnership to ensure quality healthcare is available to all.
Well, I hope one of the big takeaways you'll take from this session is that the importance of us working globally, internationally together, that our organization, although we are US based and historically have been US focused, are really expanding our work globally, and that Mothers to Mothers, although they have historically been in working a lot in sub-Saharan Africa, is also concentrating on the US because we recognize the thread and the through line is the same, and that we can come, birthequity.org is where you can find the National Birth Equity Collaborative. We're also on Twitter, on Instagram, Birth Equity, or DOC Career Perry are my handles. But just participating, we have the third annual Black Maternal Health Week coming up, April 11th through the 17th, and there'll be a lot of activities that people can participate in during that week as well. And we're going to have our Black Maternal Health conference during that week as well. That's
great. And I would urge people to support initiatives that are helping others help themselves. I think it's important that that's really how we can achieve true and sustainable change. When looking at the impact of Mothers to Mothers model, it's really built on the power of women to create that transformative change in their community. So support female-centric models where women are identifying challenges in their communities and that are empowered to respond to those needs. Dr. Joya feels so fortunate that we were able to have such a critical and timely discussion in this forum. I think it's important that we continue to shine light on the global health disparities and that we continue to push for real change, be it in the United States, be it in sub-Saharan Africa, because I don't think we can operate in silos. We are interconnected, and we have to make sure that we create good health and well-being for everyone across the globe.
Agreed. Thank you so much. It's my pleasure.
Thank you.